Question 11. Okay, a 52-year-old man comes to the a 52-year-old man comes to the physician because of 2-week history of mild abdominal cramp and diarrhea containing blood and mucus. During this time, he has also had fecal urgency. Mild pain with bowel movements. He is otherwise asymptomatic. He has hypothyroidism treated with levothyroxine. Vital signs are within normal limits. The abdomen is non-distended and non-tender. There are no massive bowel sounds are normal. Test of the stool for occult blood is positive. Results of the stool culture and testing of the stool for C. diff over parasite are negative. Colonoscopy shows Colonoscopy shows 30 centimeter continuously friable erythematous rectal sigmoid mucosa. Rectal and sigmoid mucosa no polyp and masses are noted. Which of the following is the most appropriate next step in the management? Diagnosis is ulcerative colitis, isn't it?
I think so.
Okay, ready?
Mesalamine therapy. UC is a type of inflammatory bowel disease that results in inflammation and ulceration of the colonic mucosa. And so mucosa typically beginning in the rectum and advancing proximally in a continuous distribution. Symptoms include chronic abdominal pain, weight loss, body diarrhea, abdominal bloating, tenesmus. This patient likely has ulcerative colitis as suggested by continuous friable rectal and sigmoid mucosa and symptoms of cramp, fecal urgency, bloody diarrhea. Imaging typically shows loss of ulcer markings. Diagnosis of UC is made through colonoscopy and biopsy, which demonstrates characteristic crypt abscesses. Inflammatory bowel disease can also be associated with intestinal manifestation like uveitis, arthritis, after stomatitis. Pyoderma gangrenosum treatment includes immunomodulators, biologics, and steroids. Mesalamine and anti-inflammatory medication most often used in the treatment of UC.
When surgery is done, left hemicolectomy.
Right. Can be considered in the management of UC. However, it is not the next most appropriate step. Total colectomy is generally corrective. The treatment with immunomodulators and steroids should be started first. A colectomy will help eliminate the patient risk for colorectal cancer.
His 42-year-old woman comes to the physician for a routine health maintenance examination. She has used a diaphragm for contraception for 10 years but switched to oral combined OCP 6 months ago. She is 5'6" tall, weight 70 kg, BMI 25 kg parameters. Her blood pressure at averaged 144/92 on 3 visits during the past 3 months. Our pulse is 84 per minute, respiration 18 per minute, blood pressure is now 145/90 millimeter of mercury. Which examination shows no other abnormality? Which of the following is the most appropriate next step in the match? Ready?
Yes. Switching to progesterone-only contraceptive and examining in 3 months. This patient presenting with mild increase in BP. Several office visitors' presentation suggestive of primary hypertension. Stage 1 hypertension is defined as SBP greater than 130 and DBP greater than 80. The primary factors determining blood pressure are RAS, sympathetic nervous, and plasma blood volume. The onset of this patient increased BP corresponds with the time she began to take the new oral contraceptive. Estrogen-containing oral OCPs may cause a rise in BP in some patients. While this rise BP is sometimes mild, some patients experience more significant elevations. Combined OCP also increase risk of DVT, myocardial infarction, and stroke. If a patient taking a combined OCP experiences significant increase in BP, they could be offered another form of contraception, such as non-estrogen hormonal contraceptive or IUDs. After the discontinuation of the oral containing medication, the patient should be monitored to ensure that the BP returns to normal. Next.
Yes. A 16-year-old boy is brought to the physician by his parents because of 6 month history of excessive daytime sleepiness. He is tired after sleeping more than 10 hours at night. He frequently falls asleep during class. And last week he was involved in a motor vehicle collision after falling asleep while driving home from a party. Snores at night. He snores at night. His academic performance was good, but has to deteriorated to almost failing. Examination showed normal except mildly enlarged onset. Plus, polysomnography showed normal airway, and gas action, normal sleep stages with non-short REM sleep, short REM latency, and poor sleep continuity with multiple brief arousals and 4 sustained awakenings. On the following day, multiple sleep latency resulting show REM episode REM episode at the onset of the sleep during the 3 of 4 naps with meaning sleep latency of 1 month. Which of the following is the most appropriate explanation for these findings? Okay, ready?
Yes. It is narcolepsy. Narcolepsy is a chronic sleep disorder characterized by daytime sleepiness, cataplexy, hypnagogic hallucination, and sleep paralysis that responds to modafinil therapy. Narcolepsy arises from deficient production of orexins in the hypothalamus, which may result from genetic or autoimmune causes. Orexins typically induce the secretion of monoamine such as norepinephrine throughout the brain to promote wakefulness. As a result, patients suddenly inappropriate transition into sleep during the day. Additionally, REM sleep features cataplexy, hypnagogic hallucinations, sleep paralysis occur during wakefulness. Cataplexy refers to a sudden loss of muscle tone and usually occurs in response to positive emotion. The clinical diagnosis should be confirmed by polysomnography to confirm the rapid transition into REM sleep and rule out other causes of daytime sleepiness, as well as multiple sleep latency tests to confirm decreased sleep latency. Treatment includes maintaining a regular sleep schedule, avoiding daytime nights, and in patients with severe daytime sleepiness, modafinil has a clear mechanism of action that involves increasing orexin and monoamine availability. Next.
Yes. A 23-year-old primary-gravid woman at 18 weeks of gestation comes to the physician because of 3 week history of heat intolerance and inability to sit quietly for more than a few months. She also has 5 to 6 bowel movements daily and 3.6 kg weight loss despite an increased appetite. During this period, she is 5 feet 6 inches tall Now weights 55 kg, temperature is 37 degrees Celsius, pulse 133 per minute, respiration, sorry, where respirations is 19 per minute, blood pressure 160 by 50. Examination showed diffuse thyroid gland enlargement and fine tremor of the outstretched hand. The uterus is 18 centimeter from the pubic symphysis. Fundal heart tones are 160 per minute. Free thyroxine is slightly high. Which of the following? Okay, ready?
It is PTU therapy. PTU is the most appropriate treatment of hyperthyroidism in pregnancy. For this patient, hyperthyroidism most commonly presents as it did in this patient with heat intolerance, agitation, diarrhea, weight loss, tachycardia, palpitation, tremor. The most common cause in both pregnant and non-pregnant graves, which is caused by antibody to TSH receptor leading to activation and the production of increased thyroid hormones. Pregnancy itself is also associated with increased thyroid hormones due to stimulation of the thyroid by beta HCG, due to an increased production of thyroid, and due to an increased production of thyroid binding globulin. This leads to a very high concentration of thyroid T2 and T4, but not to increase free hormone concentration. The diagnosis is made by evaluation of TSH concentration, which will be expected to be low, and 54, which will be high. Complications of untreated maternal hyperthyroidism include abnormalities in the neonatal thyroid function, spontaneous abortion, premature labor, preeclampsia, and small for gestational age newborn. Treatment often consists of symptomatic management with short course beta blockers and disease management with PTU and metimazole. PTU is the preferred. Hmm, okay. PTU is the preferred agent in the first trimester as it's associated with less teratogenicity than metimazole, which has been linked to omphalocele, tracheoesophageal fistula for anal atresia newborn. Thyroidectomy is in the second trimester is also a treatment option. Next.
Ready?
Yeah.
Yes. A 40-year-old woman comes to the office to establish care. She has felt well and represents no symptoms. Vital signs are is unremarkable. She takes no medication. Uh, family history is remarkable for kidney disease, kidney stones in her mother. The patient's vital signs are within normal limit. Examination show abnormalities. Increased serum labs are calcium is 11. Vita further testing show increased parathyroid hormone. Uh, intake parathyroid hormone by where concentration is 75 picogram per ml. The results of the 24-hour urine collection of calcium concentration is 50 milligram. Which of the following is the most appropriate cause of this patient condition? Okay, ready?
Yes. It is familial hypocalciuric hypercalcemia. Familial hypocalciuric hypercalcemia is heritable autosomal dominant caused by inactivating mutations affecting the TASR gene encoding calcium sensing receptors on PTH on the parathyroid and renal cells. As a result of decreased CH calcium sensing receptors activity, the parathyroid is rendered insensitive to normal or increased serum calcium and inappropriately released PTH in order to respond to falsely perceived hypocalcemia. This leads to increased osteoclastic bone resorption, increased GI calcium absorption, and increased renal tubular absorption of calcium and magnesium, and increased renal loss of phosphate. Patients are typically asymptomatic or have a mild symptoms of hypercalcemia, including fatigue, headache, abdominal pain, and constipation. Patients may rarely have pancreatitis as a result of abnormal pancreatic calcification. The diagnosis is established with genetic testing of the calcium sensitive receptor gene, 24-hour urine calcium excretion of less than 100 supports the diagnosis. Lab studies typically show mild hypercalcemia, hypermagnesemia, hypophosphatemia, and hypocalciuria. There is often a family history of hypercalcemia. The condition is benign. Most patients do not require treatment, although patients with recurrent pancreatitis may benefit from subtotal parathyroidectomy. It is not primary hyperparathyroidism, typically caused by PTH secreting parathyroid adenoma. Inappropriate PTH secreting that is not responsive to negative feedback results in hypercalcemia, which is often symptomatic. Symptomatic. Patients present with symptoms of fatigue, bone pain, erythriasis, abdominal discomfort, psych disturbance, lab evidence of hypercalcemia, hypophosphatemia, with an intact PTH concentration. Differentiating primary hyperparathyroidism from familial hypo-FHH can be challenging. This patient at a younger age lack of symptoms, markedly decreased 24-hour urine calcium excretion all indicate FHH as the likely diagnosis. Genetic testing can confirm the patient's thing. Okay, next.
A 27-year-old man with asthma comes to the physician for a new patient. He has chronic cough, history of chronic cough, product chronic cough, history of non-approving, chronic cough, producing productive office bottom, 3 year history of intermittent diet. He has a nasal allergy. He has nasal allergy during the past 10 years. He has had numerous respiratory tract infection, treated with albuterol 4 times daily. He does not smoke. He is 170 centimeter tall, weight 52 kg, BMI 18 kg per meter. So vital signs are within normal limit. Examination show erythematous bulky nasal mucosa. Which of the following is the most appropriate? Ready?
One moment. I'm ready.
Yes.
Is measurement of serum immunoglobulin concentration. Measurement of serum immunoglobulin concentration is the most appropriate estimate evaluation of this patient with recurrent sinopulmonary and GI infection. This constellation of symptoms is suggestive of CVID. CVID classically presents in the second to 4 decades of life. Multiple recurrent sinus and pulmonary infection, including pneumonia, bronchitis, sinusitis. Chronic lung infections can result in bronchiectasis, and infections in the GI are also frequent. Patients with CVID are at increased risk for development of autoimmune disease such as rheumatoid arthritis, autoimmune hemolytic anemia, autoimmune thyroid disease. Additionally, they have a higher risk for cancer, especially gastric cancer and non-Hodgkin lymphoma. The diagnosis is made by quantitative measurement of serum immunoglobulin, which universally shows decreased concentration of IgG and low IgA and IgM. The pathogenesis involves impaired B lymphocyte differentiation into plasma cells, leading to impaired production of immunoglobulins. As a result, failed antibody production, patients have blunt and sometimes absent response to immunization, which is supportive of the diagnosis in patients with classic findings. Treatment is with IV immunoglobulins. It's not pulmonary function testing may be indicated to measure the severity of this patient asthma and possible bronchiectasis. Spirometry will likely show an obstructive pattern with decreased FEV1 and or reduced peak expiratory flow rate. However, explain the patient's recur- it will explain the patient's recurrent pneumopulmonary and GI infection. I think it will not explain. Okay, next.
Oh, yes, I can hear you.
Okay, got it. Ready? Hmm, what is this?
17.
What are my questions?
Ready?
Give me a second. I cannot find my questions. Ugh, did I close it? Must answer questions. Answer. Yeah, here. Yeah, ready. Oops.
A study is conducted to assess the accuracy of a new rapid test to detect streptococcal pharyngitis. A total 200 patients should undergo rapid testing. These results are compared with the results of the subsequent throat culture for a group A streptococcal, group A beta hemolytic streptococcal. The study shows which of the following best represents the prevalence of the streptococcal pharyngitis within this population. Ready?
One moment. Yes, ready. What is it? That one now. Okay, so it is D. 50 over 200. Prevalence defines the number of cases of disease or a condition as a fraction of a population in consideration of at a point in time. Prevalence indicates the percentage of current cases of a condition within the population under study. Mathematically, prevalence is calculated by dividing the number of existing cases by the number of people in the population under study or at risk for the condition. In this case, the condition or the disease under study is strep pharyngitis. In this example, 50 patients were found to have culture confirmed strep pharyngitis. This is then divided by the total population, which is 200. Okay. Next.
Yes. What is your diagnosis?
I don't know. Like the
Stuck on
kerato-
appearance
the seborrheic keratosis.
or actinic keratosis? Okay, maybe. Let's read.
Oh,
Oh, it is stuck on appearance.
I thought second was seborrheic
Seborrheic
keratosis.
keratosis. Maybe. Okay, a 77-year-old woman comes to the physician because of 40 history of lesion over the forearm that has increased gradually inside. She works outdoors in her garden 3 days weekly and does not wear sunscreen maybe several times. She is concerned the lesion and the cancer she has mentioned serious illness, a photograph lesion which of the following. Okay.
Okay. The answer is observation only. Observation only is appropriate in the case of seborrheic keratosis. Seborrheic keratosis are benign growths found in middle age and old adults. Seborrheic keratosis occur in areas of sun exposure and clinically presents surround to avoid brown, sharply demarcated verrucous papules. Seborrheic keratosis can be confused with melanocytic growths, but unlike pigmented growths, they are not associated with malignant potential and are monitored clinically. Seborrheic keratosis may become inflamed, especially at sites of friction. If treatment is needed, they can be removed surgically using cryotherapy, electrodesiccation, and curettage. an excision. It is not, where was I? Maybe E. White elliptical, is punch biopsy of the lesion, the white elliptical excision may be appropriate for cases of atypical melanocytic lesions such as melanoma. Bunch biopsies and white local excision allow for the removal of the entire pigmented lesion in pathology, provides diagnosis of the lesion, including the depth invasion in cases of melanoma. This procedure may be completed in the clinic or inpatient setting under local anesthesia such as lidocaine. And patients generally tolerate this procedure as well. This lesion represents a seborrheic as opposed to, yeah, okay. Next.
Yes. A 25-year-old man comes with a physician who works after a sudden onset of sharp, bright button pain that radiates the back and knee. The pain worsens when he sits for a prolonged period or drives. He is able to walk. Use of the over-the-counter ibuprofen has provided mild relief. He has no history of serious illness, takes no medication on exhibition. Ipsilateral and contralateral straight leg raising testing is positive. Muscle strength is normal throughout. Sensation is intact throughout. Which of the following is the best? Which of the following is the most appropriate next step in the vaccine? Ready?
Sure. It is recommendation for normal activities as tolerated. Lumbar disc herniation is a common cause of sciatica, also known as lumbar radiculopathy. This herniation most often occurs following chronic disc degeneration combined with a minor traumatic event, such as bending or lifting a heavy object, causing an acute increase in the intradiscal pressure. This herniation typically presents as acute back pain with symptoms of lumbosacral radiculopathy, including acute extremity pain, and weakness in a dermatomal and myotomal distribution with respect to the impinged spinal nerve. Acute extremity pain and weakness in a dermatomal distribution and myotomal distribution with respect to the impinged. Yeah. Okay. Sciatica is diagnosed clinically through a combination of history and examination maneuvers, including the straight leg test, in which flexion of the hip while the leg is held in extension at the knee reproduces pain in the lower back that generally shoots down the leg. Lumbar imaging with MRI and CT scan is useful for patients with severe motor or sensory dysfunction. Lumbar imaging CT. Okay. Okay, but it's not required for most patients with mild or moderate symptoms. Most patients with sciatica show spontaneous improvement with conservative management, including analgesia. Physical therapy, um, normal activity as tolerated. It's not E. What is E? Recommended bed rest for 1 week and use of lumbar brace. Immobilized use of a lumbar brace immobilize the back. Studies have shown no benefit for bed rest, which can lead to increased pain and prolonged recovery for some patients. Okay. Activity as tolerated and physical therapy are more likely than bed rest to benefit the radiculopathy. Okay.
Next.
Mhm.
A 2-year-old boy is brought to the emergency department 30 minutes after he was involved in a motor vehicle collision. He was sitting unrestrained on his aunt's lap in the front passenger seat during the collision, and the automobile's airbag deployed on impact. Paramedics at the scene immobilized his spine with cervical collar, and his head was tapped backward during transport to the hospital. He has no history of serious illness. receives no medication on arrival. He is crying and moving. Extremity temperature normal, blood pressure 120 respiration 25 per minute, blood pressure 110 by 60, long oxygen saturation 99%. Examination show abrasion over the face and the neck. Each of the following.
Ready?
Yes,
It is X-ray of the cervical spine and chest. Blunt trauma to the head, neck, or chest, as seen in this pediatric patient, is a common presentation to the ED after motor accident. The first steps in management such patients are to assess the airway, breathing, and circulation, along with immobilization of cervical spine until further examination can be performed. Management after initial survey is dependent on any concern findings such as airway compromise, respiratory suppression, or circulatory dysfunction. In this patient who was being held by a family member in the front seat of a vehicle, in which the airbags deployed during collision, it's fair to assume that the patient was struck by the airbag. On arrival, the patient is mildly tachycardic and mildly tachypnea, though for his age, vital signs may be appropriate. At the time of assessment, there is no clear indication of primary surgery-related immediate life threat, and thus he does not require immediate intervention prior to further diagnosis. His spine was immobilized with the cervical collar and backbone unseen. The most appropriate next step, given his stable presentation, is to assess the integrity of structures in the cervical spine and thorax, as these are more likely to be damaged due to airbag deployment. This is also particularly important for this patient because there are abrasions over the face and neck, again giving evidence of airbag contact. If the patient were to have respiratory collapse from resultant laryngeal or tracheal injury, intubation would be necessary. However, if a cervical spine fracture was not identified prior to this, there is an increased possibility of spinal cord injury during intubation. Notably, X-rays have limited sensitivity for pediatric blunt traumatic injury, but the structures are not yet fully ossified at age 2 years old. Advanced studies such as CT and MRI may be necessary depending on the clinical presentation, though X-ray imaging is an appropriate first choice. It's not CT scan of the chest and abdomen is a reasonable option in a patient presenting with bone trauma. These images will offer insight into interthoracic pathologies that may not be seen on X-ray or physical exam. However, in this patient who's stable at this time, X-ray sufficient modality for initial assessment and will also reduce the radiation exposure to this pediatric patient. And it's not sedative. Yeah, IV given sedatives will not be appropriate in this stable patient who can currently comply with medical evaluation. If his discomfort was keeping personnel from treating him appropriately, then sedatives may be appropriate. However, the patient is cooperative and stable. Okay, next.
Yoga following is the most appropriate initial step in this manage. A 52-year-old man comes to the physician 2 days after noticing that his eyes and skin appear yellow. 4 days ago, he received the diagnosis of sinusitis and began treatment with traumatic substance. During the past 6 months, he has traveled Nicaragua and Belize. He has been sexually active with 12 partners during the past 2 years. He uses condom inconsistently. He drinks 3 to 4 beers weekly. He does not smoke cigarette or illicit use illicit drug. Temperature normal, pulse 72, respiration 14 per minute, blood pressure 136 by 80. Examination shows generalized jaundice and a diffuse macular non-blanching rash. Diffuse macular non-blanching rash. Over the chest and the back there is scleral icterus. Hemoglobin 13.2, bilirubin 5 0.5, D rate 2. AST is high, AST 372, hepatitis B negative, positive, which of the following is the most appropriate next step in the management? Ready?
One moment.
Ready?
One moment. NCP so far is indirect. Okay, ready. It is discontinuation in TMP-SMX. The patient is presented with acute hepatitis with jaundice, hyperbilirubinemia, and increased serum liver enzyme. Causes of acute hepatitis include viral infection, excessive alcohol use, um, medications and supplements, or autoimmune disease, and ischemic injury. IV drug use is a major risk factor for viral hepatitis. Especially transmission of Hep B and Hep C. Serologic testing for viral hepatitis include anti-Hep A, IgM, and IgG antibodies, anti-Hep B, IgM, and IgG antibodies, and more specific and multiple anti-Hep B antibodies and antigen as a result of propensity of Hep B to cause chronic and subacute infection. In this scenario, the person has been found to have positive Hep B surface antibody with negative antigen, indicating the patient is likely immunized or has a previous Hep B infection. MPHCMs have been associated with acute liver injury, often with features of drug allergy, including fever rash as seen in this patient. He has fever, no, really, he has a rash, and he has I drug. Okay, he doesn't use drug. Okay. In the setting of recently beginning treatment with MPSM antibiotic with no hepatotoxicity, discontinuation is the most appropriate thing. Okay. Next.
A previously healthy 37-year-old man. A previously healthy 37-year-old man comes to the physician uh, because of 2-day history of fever, persistent cough, productive of yellow sputum. He has not had shortness of breath. He does not smoke. His temperature is 37.9 degrees Celsius. Pulse 88 per minute, respiration 16 per minute, blood pressure is 134 by 82. Scattered bronchi are heard bilaterally during the examination. He has an episode of severe coughing. Next of the chest showing no abnormality. In addition to treatment of this patient's symptom, which of the following is the most appropriate pharmacotherapy?
Ready?
Yes,
It is. No, No additional treatment indicated. This patient is presenting with 2 days of low-grade fever, persistent productive cough, and physical exam that only discloses bronchi. X-ray of the patient shows no abnormalities. Because of this, the most likely diagnosis is viral respiratory infection such as bronchitis. In general, guidance for treatment of viral respiratory infection is symptomatic treatment with antitussive and antipyretics. Antibiotic treatment is not indicated in viral respiratory infection, in contrast to bacterial respiratory infection where antibiotics is the mainstay of treatment. Antibiotic stewardship is an important part of the practice medicine by physician, and unnecessary prescribing antibiotics can
What
lead
does
to.
this stewardship means?
I don't know. I don't know. Mm, I don't know. Is prescribing antibiotics can lead to increased resistance. You can Google it. Increased resistance patterns in, in generally susceptible bacterial lines, um, along with adverse effects of antibiotics use, such as Clostridium difficile. Patients should be counseled about appropriate use of treatment in these cases, as community health belief that antibiotics are used for viral respiratory infection remains somewhat common.
Okay, next.
Mhm.
If a 17-year-old boy is come to the physician because of spotted mass that has become increasingly painful during the past 3 days, he is not certain how long the mass has been present. There is a history of trauma. She is sexually active with several partners and uses condoms impulsively. Examination shows a tender mass protruding. Okay.
And then the answer is infection of the epididymis. Acute epididymitis. Infection of the epididymis most commonly present with unilateral spot of pain associated with tender swollen mass over the posterior aspect of the testis. In severe cases, it can also present with localized redness, dysuria, and systemic symptoms such as fever, rigors. Physical exam will show an intact hemostatic reflex, which helps differentiate it from testicular torsions, in which we know that. However, sensitivity and specificity of these maneuvers is notably imperfect and limited and should not be relied to determine the diagnosis. The underlying cause in most commonly infection with chlamydia or Neisseria in men under 35 and E. coli in some, or Pseudomonas in older men and in those practicing insertional anal intercourse. Evaluation should include urine NAT testing for chlamydia and gonorrhea, as well as urinalysis and urine culture. Treatment includes empiric ceftriaxone for gonorrhea and doxycycline or zithromycin for chlamydia in patients at risk for STI. Levofloxacin or TMPSMS are recommended agents for patients at low risk for STI or in those in whom the enteric organism is the suspected pathogen. Symptomatic management include scrotal elevation, application of ice, and NSAID.
A 52-year-old woman is admitted to the hospital for treatment of acute diabetic colitis. After 2 days IV antibiotic therapy, after 2 days IV antibiotic therapy, she has a temperature of 102 abdominal rigidity, leukocyte count 17,000, leukocyte count 17,000, with 15% band. Physical examination explains to the patient that the patient that she will need the urgent sigmoid colectomy. Depending on the findings, she may require colostomy. Urgent, the patient agrees to do the operation but refuses under the colostomy. The patient's husband is in the hospital but is not with the patient at this time. Which of the following is the most appropriate next step? Ready?
Yes. Engage the patient. Yeah, discussion of the possible operative findings and management options. Before considering the patient, Before considering the patient's decisional capacity to consent for procedure or proceeding with a procedure, the patient must be provided with the information needed to make an informed decision. Ensuring informed consent has been obtained in a physician is a physician duty before performing a procedure in a non-emergent setting. Informed consent fulfills the ethics principle of autonomy, which dictates that patients should be able to make their own decision about their healthcare, including whether to accept or decline the procedure. Informed consent also benefits the physician-patient relationship and encourage physicians to truly review the indications, benefits, and risks of the procedure and whether alternatives could be considered. Informed consent in this case must include an explanation of possible operative finding and management options, as well as the risk and benefit of both agreeing to and declining the options. Is not E. What is E? Perform the operation without colostomy regardless of finding will be premature. At this point, the patient has not received relevant information to make informed decisions. Once she receives this education about all the possible options, she may come to a different decision. I didn't choose
Sorry.
because here it seems like the patient is in like emergency situation, right? She has fever, abdominal rigidity, and all these things. So even with that, you're still gonna go ahead and talk to her a lot, like do all these questions.
Sorry.
You see, like I was between A and E. I
Yes.
performed explanation. Yeah,
Yes. Yes. I gave the answer E.
because for me it was like she's in a emergency situation, right?
Yes.
Kind of, because she's unstable. She has fever. She has like abdominal rigidity, all these things. So I was like, there is no time really to start talking to her. We just go straight into the surgery. So that's why I was between E. But here they say that you still have to kind of like she's not it's not an emergency situation, so you still have to talk to her and give her order. Is that am I understanding it right?
Yes.
Okay.
For like, I don't understand about the US system. Like, nothing is emergency apart from the like life-threatening condition. This patient need surgery, isn't it? This patient needs
Yeah,
urgent
yeah,
surgery.
yeah.
Why we waste our time on talking?
Yeah, that's why I was okay.
Like
That's why
discussion and this type of thing is a time consuming. If
yes.
patient dies in between those discussion, who will be responsible? Maybe nobody is responsible. I think
No,
that
that's why
like every people scared about uh, canceling the license. That's why talking is the main thing. You you understand what I'm uh,
No, because in other questions, there is like, okay, when the patient doesn't have the capacity to give informed consent, you just have to go ahead and do what you think is best. But here it's like it's an emergency, but you still have you. I guess, but I guess okay. I guess the thing is, if the patient cannot talk, that's when like the patient is it's not just an emergency, but the patient cannot talk. But here is an emergency, but the patient can talk, so you still have to get informed consent. If here the patient was unconscious, like it's an emergency, and the patient cannot talk, I guess be the it will still not be the answer because we wouldn't know that the patient don't want the colostomy. I guess the option will be ask for the the husband consent, ask the consent from the husband. Okay, okay, I'll just take it like that. As the patient can, is an emergency, but the patient can talk, so you still do the informed consent. You still need to get the informed consent. Okay.
if like if the patient is if patient's husband give permission but patient is not ready. This patient is what can I say, this patient is hemodynamically stable, so he can took her decision, like she she refuses to undergo colostomy. If he is, if her husband agrees, but if she does not agree, then what will happen?
And the patient is what is stable or not stable? I don't understand what.
Like this one is
Uh-huh,
stable, this patient is
uh-huh.
stable, like he is hemodynamically stable, like he understands what we are talking about, isn't it? She is not
No,
in a deleterious state.
no. It seems like this question, the patient is unstable, but she can still talk.
Okay.
You see what I'm saying? Like there is unstable, like they take you to the emergency room, you're in a coma, you cannot talk, you cannot say anything, you cannot say yes, I want the surgery. That's one kind of unstable. Then there is unstable where you are blood pressure is low, everything is bad, rigidity, abdomen, but you can still talk to the patient. You can still say, patient, you can still talk to the doctor. You can still say, doctor, I don't want this. I don't want, please don't touch me, don't whatever. That's another kind of, this is that kind of stable is of unstable is what is happening with this woman. So she's unstable, but she can still talk. You see, she said that no, I want colectomy, but I don't want colostomy. But she's unstable. We can see the vital signs. So here you don't go and ask the husband. You don't need to ask the husband because the patient can still talk. Now, if the patient was the type of unstable that is, I'm in the emergency room, the she cannot talk, she cannot say anything, she whatever, then yes, you have to ask the husband because the patient cannot talk. Did that answer your question or that was not your question?
Yes,
Omar.
yes,
Oh,
yes. I
okay.
am thinking.
Okay,
Very
yeah.
complex thought. Let's
It
be simplified.
yeah.
Don't think
Mhm.
so
Yeah.
complex way.
No, I'm saying it because I've seen questions,
Yes,
where the patient is unstable, so you go straight to the husband or you go straight to the surgery because the patient is unstable. Fine, the husband is not there, whatever, the patient, we don't have access to the family. So you go straight to the surgery. That's why I was confused with this one where it's like it's unstable, but we're still asking her. We're still asking her questions. But so it's just keep it in mind. Just keep it in mind.
okay. Mm, mm, wait 1 second. A 16 a 16-year-old girl is brought to the physician. A 16-year-old girl is brought to the physician because a 16-year-old girl brought to the physician because her parents are concerned about eating habits. During the past 6 months, she had stopped eating meals with her family, expressed concern about her weight, and lectured the family about improving their dietary practices. The patient says that eating more nutritious food has decreased her appetite. She says the fact that she says that the fact that she has enough energy to be on the cross country running and cheerleading teams shows she is eating appropriately. She worries that she does not have right body shape for fashionable clothes and thinks that she would be more popular if she would wear dress, but if she receives grade A in school, but worries she will not able to maintain her grade point average because isn't 5 feet weight, BMI is 17, so looks like anorexia nervosa. Let's see.
Is anorexia. Anorexia characterized by an intense fear of gaining weight, decreased self-worth of body related to body weight, and consequent restricting fasting, exercise, or binge eating, purging behavior, leading to insufficient nutrition. Patients with anorexia nervosa may have a BMI less than 17, though patients with malanorexia may have a BMI greater than 17. Normal limit is at 80.5. Amenorrhea is common and reflects insufficient nutrition. Physical examination of patients with anorexia can show dry, scaly skin and fine hair or hair loss caused by decreased protein stores, though these signs are not present in all patients. In cases, severe cases, signs of hypovolemia such as tachycardia, hypotension may be present. Risk factors for anorexia nervosa include perfectionistic tendencies, as an involvement in sports that empathize body aesthetic, like dance, gymnastics, cheerleading. Treatment of anorexia is through combination of medical and through combination of medical and psych approach and involves correcting fluid and electrolyte abnormalities along with behavioral and pharmacologic therapy.
Okay. During observation of a surgical procedure, a physician notices the anesthesiologist falling asleep. The observing physician says the anesthesiologist's name. He walks up. He wakes up and attends the remainder of the operation appropriately. Mm, After the procedure, the physician approaches the anesthesiologist who says that he was up late last evening attending to emergency procedure. The surgeon later informs that the physician that these anesthesiologists frequently falls asleep in the operating room. Which of the following is the most appropriate next step for the physician? Ready?
Okay. Is a report the anesthesiologist to the chief of the medical staff. Um, fatigue is an important and common challenge facing healthcare providers. Fatigue occurs due to a variety of factors, including long or irregular work hours, and can result okay, can result in impaired cognitive performance and disease. Like in this case, the reason for the anesthesiology fatigue is unclear, but the observing physician has been made aware of a pattern of behavior of the anesthesiologist sleeping during surgery, which is inappropriate It can compromise the patient's safety. The most appropriate next step is for the observing physician to report the issue to the chief of medical staff. The chief of medical staff is responsible for overseeing physicians and other medical personnel. Chief of medical staff is the most appropriate person to identify and address the source of whatever. Recommend the anesthesia and undergo sleep study is incorrect. Sleep study are appropriate for identifying sleep disorder. The reason for anesthesia fatigue is unclear based on the observed behavior. It is possible that the behavior is occurring due to another cause. The chief of yeah, okay. Next.
Next. A 32-year-old woman comes to the physician because of a 1 week history of tenderness and swelling of her neck. She has no history of serious illness, medication, oral contraceptive, temperature, high respiration rate, blood pressure. No. Examination of the neck shows no mass. The thyroid gland is slightly enlarged and tender. No nodules are palpated. The remainder of the examination shows no abnormalities. Serum studies show a thyroid TSH is zero point 0.3, antiform is 11.5. Antithyroid antibodies are not detected in thyroid scan. Decreased uptake, which of the following is most likely diagnosis?
TSH is 0.3. TSH 0.3 is a bit low. And then T4 is 11.5. 11.5 UGDL. It's normal. A bit low and normal. Suppurative, enlarged and tender. Ready?
Yes.
Okay. It is subacute granulomatous decavant thyroiditis. Subacute granulomatous or decavant thyroiditis is a rare form of thyroiditis that is characterized by the inflammation of the thyroid gland, the presence of granulomas. It is typically preceded by viral infection, such as an upper respiratory infection, and is more common in women. Symptoms may include pain and tenderness in the thyroid area, fever, fatigue, and swollen thyroid gland, along with symptoms of hyperthyroidism like anxiety, tremors, weight loss, diarrhea, menstrual irregularities, hot flashes, tachycardia, hypertension, sweating. Treatment typically includes NSAIDs and steroids to reduce inflammation and pain. The condition is usually self-limiting and the thyroid gland typically returns to normal function within a few weeks or months. However, in some cases, the patient may experience temporary or permanent hypothyroidism following the initial period of inflammation. Um, and generally transient hyperthyroid symptoms. So the acute or decadent thyroiditis should be suspected in any patient who has an enlarged thyroid, history of recent viral infection, and increased thyroxine concentrations with decreased TSH concentration. It's not acute suppurative thyroiditis. It's characterized by inflammation and infection of the thyroid gland, typically by bacterial pathogens. Symptoms consist of fever, neck pain, dysphagia, and erythema. The most common cause are strep and staph. In contrast to this patient, thyroxine concentration is generally low and normal TSH concentration. It's normal, okay, thyroxine concentration is low, normal, and TSH concentration is increased because of the destruction of thyroid gland tissue, making this answer incorrect. So T3, T4 are low and TSH is increased. And it's not C. Exogenous use of thyroid hormone will present with symptoms of hyperthyroidism similar to those in this patient. It will not be associated with an enlarged thyroid. Okay, got it.
Ready?
Yeah.
7 days after cesarean of 7 days after cesarean delivery for arrest of this 27-year-old woman, Gravida 1 para 1 remains in the hospital because of spike in temperature and since delivery. Treatment with broad spectrum antibiotic has not resolved for fever. She feels well when she does not have fever. Lab studies 35 weeks of gestation positive streptococcus. She was treated with intrapartum penicillin. Her temperature is 101. Examination showed Weber, which of the following is most likely diagnosis.
Ready?
Yes.
Sorry. Septic pelvic thrombophlebitis. Uncommon sequela of pregnancy that should be considered in this patient who's persistent febrile despite appropriate antibiotic treatment for endometritis. It's more common in patients with existing pelvic infection at the time of delivery, such as endometritis, chorionitis, and in those that have C-section deliveries. It occurs due to a combination of pelvic vein inflammation, often from surgery, infection, venous and hypercoagulopathy in pregnancy, leading to thrombosis of the ovarian and other pelvic vein. These thrombosis subsequently become infected, leading to persistent fever despite antibiotic therapy. Patients most commonly present in one or two ways. Patients with septic ovarian vein thrombophlebitis often appear ill, have abdominal pain in addition to their fever, and may have palpable core on abdominal exam. Deep septic pelvic thrombophlebitis present as in this patient with minimal features other than persistent fever and with the patient feeling well, not fe- often feeling well when not febrile. Diagnosis may include lab studies with blood cultures or CT imaging. However, these studies are often unremarkable, making the diagnosis clinical. Treatment includes addition of systemic anticoagulant to the antibiotic
Why it
therapy.
is not endometritis? Endomyometritis.
Endomyometritis is an acute polymicrobial infection of the endometrium and myometrium with normal vaginal flora. Patients typically present with fever, mucopurulent discharge, and severe tenderness of the uterine fundus. Risk factors for developing endomyometritis include premature or prolonged rupture of membranes greater than 18 hours, spontaneous or elective abortion, C-section, and placement of an intrauterine device. This patient does not have a mucopurulent discharge or uterine tenderness. Usually, the septic is always the same
Stem.
question with septic and with whatever the septic thingy. It's usually like the patient just gave birth and she keeps having fever, and they gave her all the best antibiotics, the right antibiotics, but she keeps having fever. That's usually the same question.
Okay. a 72 year a 72-year-old woman comes to the physician. A 72-year-old woman comes to the physician because of generalized fatigue for 1 week. During this period, she has occasionally had lightheadedness on standing up quickly. She has not had chest pain, shortness of breath. She has hypertension, coronary artery disease. Medications include amlodipine, hydrochlorothiazide. She is alert, oriented to the person, place, and time. Her temperature is 37 degrees Celsius, pulse 38 per minute, respiration 14 per minute. Blood pressure 80 by 40. Crackles are hard in both lung disease 1 is to a grade 2 by 6. Systolic murmur is hard at the fourth left intercostal space with radiation to the carotid. Uh, Fourth left intercostal space with radiation to the carotid. Peripheral edema is sorry. There is
I
no
didn't.
peripheral edema. ECG is shown. Which of the following is the most rapid next? Ready?
Yes. One moment. It is insert cardiac pacemaker. This patient with fatigue, orthostatic hypotension, ECG showing disassociation of P-waves and QRS complexes as a presentation consistent with third-degree AV block. Third-degree AV block occurs when no sinus impulses are transmitted through AV conduction pathway, resulting in complete dissociation between a atrial and ventricular contraction. Ventricular contraction occurs secondary to a junction rhythm, which can cause a bradycardia and decrease cardiac output. ECG shows P waves that are present at regular intervals and QRS complexes that are present at regular intervals. However, the P waves and QRS complexes have no association with each other. Patients can present with variable symptoms depending on the rate of escape of the ventricle. Symptoms include fatigue, dyspnea, chest pain, syncope. Patients may also present with syncopal episodes and sudden cardiac arrest. Bradycardia is common. Treatment for all patients with third degree AV block is cardiac pacemaker.
Ready? Next. Pulse. Previously healthy. A previously healthy 5-year-old boy is brought to the office by his mother because of sudden onset severe abdominal pain. 1 hour after he ate dinner, he receives no medication. Immunizations are up to date. He was adopted at birth. There is no information available about biological family history. He receives no medication. Immunizations are up to date. He was adopted at birth. There is no information available about biological family history. His temperature is 100, pulse 100 per minute, respiration 20 per minute, blood pressure 85 by 60. Examination shows congenital icterus. There is no guarding or a moderate tenderness to palpation with the right upper quadrant. The spleen A tip is palpable. Presence hemoglobin 8.3, leukocyte 11,000, reticulocyte 7%, serum bilirubin 4. Direct antiglobin combs is negative, small uniform spherical erythroid region. The following is the most appropriate cause of this patient's abdominal pain. Biliary. What is your diagnosis?
Um, it's some kind of blood disorder. I don't know exactly, but some kind of spherocytosis. Some kind, it doesn't really matter of blood disorder.
Is
Um, it definitely like
why
you can delete
bilirubin
all
is
the other
high?
because if it's some kind of blood disorder, the blood is getting destroyed, so the bilirubin will be increased.
Oh yes, yes. And for bilirubin, If it is extra vascular hemolysis, then finding is hemolysis, like splenomegaly. Okay.
So it's oh, never mind. It's biliary colic. This patient with evidence of hemolytic anemia, high reticulocyte count, blood smear demonstrating small uniform spherical spherocyte likely has hereditary spherocytosis. Hereditary spherocytosis can occur if there are mutations in one or more proteins, expectorant ankyrin band 3 or band 4.3, that link the erythrocyte in the membrane skeleton to the outer lipid bilayer. These mutations are inherited in an autosomal dominant pattern. Spherocytosis results from the progressive loss of erythrocyte membrane over time and gives the erythrocyte a spherical shape as the surface area decreases but the volume of the shell remains unchanged. This impairs the erythrocyte ability to conform in small vessels of the microcirculation, especially within the spleen where spherocytes accumulate. Patients often present with splenomegaly, hemolytic anemia, and pigmented gallstones, which can lead to biliary colic as seen in this patient. Peripheral smear will show phagocytosis, which are dense dark cells with loss of central pattern. Reticulocytes may be seen during the acute hemolytic episodes, which appear as large, pale blue erythrocytes. Definitive management is first splenectomy in this scenario. Biliary colic is the most likely cause of the patient abdominal pain, secondary to gastro formed by hyperbilirubinemia. Splenomegaly may be caused by liver disease, hematologic malignancy, splenic sequestration infection, as well as many other conditions. The finding of a small uniform spherical or in the setting of okay, I am ready.
So we have done this biliary colic. Question number 30. Now
Yeah,
question
we're everyone. Mhm.
31. A prospective multi-center study is conducted to determine if an oxygenation OI index greater than 20 predicts death in patients who develop acute respiratory distress syndrome after a bone marrow transplantation. A total 120 patients have enrolled. The results show, according to these results, following represent the sensitivity of this index. How you calculate this sensitivity? You found I tried,
Yes, you tried.
but
I haven't found it. Let me see. Sensitivities, people that tested positive, tested positive, people with the disease, people that tested positive, so it's oxygenation greater than that level of ARDS. People that tested positive or a total of people that have the disease. Mm, okay, maybe 20, no, maybe 60 or 80. Okay, let's see. I got 75.
okay, let's see. And you were wrong.
I'm wrong. This is whatever. At this point, it's 80. What
Why
the
it
fuck?
is? so complex. I don't know.
Yeah, this one is a bit complex. I don't even know what is the positive or
Yes,
negative of this.
even I am unable to find out
Yeah.
what they are looking for. Like what is true positive, which one? Okay,
Yeah.
let's see.
Sensitivity is the ability to detect the disease if it's present. High sensitivity is therefore useful for ruling out the disease. Sensitivity can be calculated by the equation true positive over true positive or false negative. The cutoff value for a test can be adjusted to optimize disease detection, resulting in changes in the sensitivity and specificity by changing the number of false negative and false positive. If the given scenario, in the given scenario, the true positive represents patients with oxygenation index greater than 20 who later die, who die greater than 20, so 60. While false negatives represents patient with oxygen index less than 20 who later die. The sensitivity can be calculated as 60 over 60 plus, so I guess 60 over 60 plus 15, which is 80. SNAT C 75 corresponds to the positive predictive value, a statistical measure that defines the likelihood that a person has the disease given a positive test. Weighting can be calculated by true positive over true positive, false negative, which will be like the 60 over 80 that I did. So is test positive over total of people that have the disease. Mm, 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 mm.
Like which point I will choose? 20%. Like the death patient.
I don't. It says that the true positive is the 60, the people that have the oxygen index more than 20 and that die. Those are the true positive. To people that tested positive, so I will get 60 over or the number of people that have the disease. That have the disease. I thought it was 60 over 80. I don't know, 60 people that have the disease. 60 over 120. No?
This question is very complex.
Yeah, people that have the disease, 60 over 15. So it will be this one. Oh, okay. 60 over 75 times 100. Mm, 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 mm. Okay. I don't know how to find the, I mean, there's kind of explain how to find the true positive and false negative. You kind of have to rearrange this table. This table is not given in the proper, the way that you usually gave it. But in order to rearrange, you kind of need to understand what they're asking for. That's the part
Yeah,
where yeah, you
what they
cannot,
are asking for.
yeah. But when I do it through the videos that I had sent you, sensitivity is the people that tested positive over the people, all the people that had the disease. Yeah, I think that was that. So the people that tested positive, I guess the people that tested positive, whatever, will be those ones. That's kind of how I found the 60 over the people that had the disease. Now, I was wrong because I thought the people that had the disease will be this total, but it seems like it's this total. So the disease is kind of the people that die, and the exposure is kind of if you have oxygen saturation more than 20. I think that's kind of how you have to see. I know you usually look for the exposure and the outcome. So the exposure will be uh, uh, oxygen saturation more than 20, and the outcome will be the people that die. Try to see it like that and see if you can find, you know, yeah. But you still have to make your own table with that. So that will probably take some time.
Yes.
Yeah. Yeah.
Okay, next.
Mm.
And otherwise, 47-year-old woman gravitated to comes to the physician because of hot flushes that began uh, hot flushes that began 8 months ago has become more frequent during the past 3 months. Mens now occur at irregular 40 to 60 days interval, light flow, and last 2 to 3 days. Her last menstrual period was 2 months ago. Her pulse is 85 per minute, respiration is 16 per minute, blood pressure is 140 by 80 mmHg, pelvic examination to know abdominal, which of the following is the most appropriate. Next, yeah, sorry, ready?
Mhm. Is a discussion of hormone therapy. Most appropriate next step in management is discussion of hormone therapy to treat these patients' symptoms of menopause. As women age, the ovarian reserve is depleted, and they have fever ovulatory cycles until menstruation stops completely, referred to as menopause, which typically begins around 50. Menopause is characterized by the lack of ovarian estrogen production, resulting in manifestations such as vaginal atrophy, hot flashes, night sweat, sleep disturbance, and mood changes, and may also be present changes. In response to decreased estrogen, FSH and LH lack negative feedback and are increased. Menopause is often a clinical diagnosis, but this lab value may be obtained if the diagnosis is unclear. Because many of the symptoms of menopause are caused by a deficiency of the estrogen. By deficiency of estrogen, hormone replacement therapy with estrogen with or without progesterone mitigates many of the adverse effects. While hormone repair has been attributed to an increased risk of breast cancer, hypercoagulability, and cardiovascular mortality, generally considered safe for a limited period of time at the lowest effective dose in patients who are otherwise healthy or at average risk for. Yeah. The decision whether to start HRT is individual, and discussion should be tailored to each patient. It's not the measurement of estradiol concentration may be used in the evaluation of menopause, in which concentrations will be expected to be low. However, this diagnosis is clinical. This patient has all the symptoms of menopause at an appropriate age, mm, and confirmatory testing with estradiol is not necessary. Next.
Yes. A 28-year-old man comes to the office for a follow-up examination 2 days after undergoing HIV antibody testing. The patient is sexually active with the patient is sexually active, only men, and uses condom inconsistently. He is asymptomatic, has no severe illness, he takes no medication. Results of the HIV antibody antigen testing 6 months ago were negative. The patient does not smoke cigarettes, drink alcohol, or use illicit drug. He is 180 centimeter fat, little when installed weight is 82 kg. Vital signs are within normal limit. Examination shows no abnormality. CD4 T lymphocytes 724 normal. Plasma HIV viral load is 16,000, 1,69,000 copies. Serum which began to cry and is comforted by her mother. In addition to expressing empathy, the most appropriate next step in the management to address show the following. Ready?
Yes. Is a patient fear about having HIV. After the patient expresses emotional distress about a medical condition, the physician should initially focus on feelings rather than facts and encourage the patient to elaborate on their emotional and in open-ended way. Listening to this patient's concerns and validating the underlying fears about having HIV will decrease the patient distress and improve the therapeutic alliance. Encouraging elaboration will also increase the patient's understanding about the source of patient's distress and allow the physician to tailor further discussion to the patient's specific concerns. HIV can present with diffuse lymphadenopathy, diarrhea, sore throat, fever, and weight loss. Patients may also present with opportunistic infection or maybe asymptomatic. Their therapy typically includes combination of at least three different drugs from at least two different antiretroviral classes. Patients will receive prompt treatment and exhibit long-term compliance can be expected to live equivalent life to those who do not have HIV infection. Initiation of antiretroviral therapy promptly is critical to
Um, he has too many episodes. 7 and 2 years ago, the resulted psychiatric hospitalization. The episodes are preceded and followed 6 months of the depression, physical no abnormality on mental status examination. Mood is normal. He feels. He says that he feels fine. Would you like to discontinue? Discontinuation of the medication will increase the risk of suicide. Ready?
yes, is lithium. Lithium, most stabilizer medication used for treatment and acute mania and maintenance of bipolar disorder to prevent the recurrence of manic or depressive episodes. It's also used to treat refractory MDD. Lithium carbonate mechanism of action is unclear, but is thought to involve altered cation transport, modulating reuptake of serotonin and norepinephrine, and exerting a neuroprotective effect. It has anti-suicide properties independent of its mood stabilizing properties. Many patients have shown that lithium decreases suicide rates for patients with many studies have shown that lithium decreases suicide rate for patients with mood disorder over long term. The decrease in risk for suicide is most prominent in bipolar disorder, and but it's also present in MDD. Thus, discontinuation of lithium is likely to increase the patient risk for suicide. Okay.
Why it is not SSRI? SSRI has a suicidal tendency.
SSRI medication is used to treat unipolar depression and anxiety. Um, it has not been associated with decreased suicide risk. It's not effective for treatment of bipolar.
Okay. A 14-year-old boy is brought to the emergency department 3 weeks after stepping on a nail. He was wearing tennis shoes that at the time of the injury. His mother treated the puncture wound by cleansing it with soap and water. Initially, the pain subsided, but it was returned and worsened over the past 3 days. He now refuses to bear weight on his foot. He is febrile. Examination shows redness, function, exchange of radiolucence of the superior cell newborn formation of the metatarsal. Which of the following is a causal organism? Ready?
Okay, so the monas, osteomyelitis, an infection of bone and bone marrow that typically presents acutely, subacutely, chronically from direct inoculation of the hematogenous spread from a distal site. Risk factors include traumatic injury, diabetes, peripheral vascular disease, IV drug use, and presence of prosthetic device or indwelling hardware. In adults, it commonly occurs through direct spread from an adjacent soft tissue infection and less frequently from hematogenous seeding of bacteria to that site. In children, IV drug users and dialysis patients with indwelling catheter, hematogenous seeding is common given the propensity um, for bacteremia and distant seeding of the involved site. Patients typically experience pain, difficulty bearing weight, underlying tenderness to palpation. Lab studies may show leukocytosis. Increased inflammatory markers on imaging osteomyelitis can present with localized osseous erosive changes of the bone as seen in this patient X-ray. Treatment of osteomyelitis involves prompt administration of broad-spectrum antibiotics. Pseudomonas is a likely cause of osteomyelitis following a puncture wound to the foot, particularly if there has also been exposure to water or moist environment. Now, Burkholderia cepacia, gram-negative rota causes hospital-acquired pulmonary pneumonia and pulmonary infections in patients with cystic fibrosis and granulomatous disease. In immunocompetent patients, the pathogen often does not cause infection because this patient has a history of it's now a Canella corrodens gram-negative facultative anaerobe that is part of the normal oral flora. Echinacea has been indicated of cases of endocarditis, osteomyelitis after human bites. Okay, next.
A 42-year-old primary gravid woman and 34 weeks of gestation is brought to the emergency department because of 4-hour history of decreased fetal movement. Pregnancy has been complicated by gestational diabetes due to insulin. She has no history of serious illness or other pregnancy complications. She is 160 centimeters tall. Weight is 82 kg prior to the pregnancy. BMI was 32 kg per meter square. She has had 18 kg weight gain during the pregnancy. Temperature 37, pulse 74, blood pressure 135, 70. Cervix is not dilated. Cervix is not dilated. The remainder of the examination shows no abnormality. His finger stick blood glucose is 110 milligram per deciliter. Fetal heart rate tracing is shown. This pattern is unchanged during the next hour. Each of the following is the next step. Ready?
Yes. It is C-section, uteroplacental insufficiency and fetal
It is
hypoxemia.
late deceleration, isn't it? From
Do
onset.
not know.
Yes.
Think so, yeah. Uteroplacental insufficiency and fetal hypoxemia can present with late deceleration of fetal heart rate tracing, which are defined as gradual decrease in the fetal heart rate that begin after the peak of uterine contraction and nadir more than 30 seconds after initiation of heart rate decline. As seen in this patient, risk factors for development of uteroplacental insufficiency include diabetes, hypertension, advanced maternal age, okay, anemia, cocaine use, smoking, coagulopathies, late-term pregnancy, and uterine infection. Fetal hypoxemia and consequent late deceleration can also be caused by severe uterine contractions, the maternal hypotension and hypoxia. Treatment of heteroplacental insufficiency consists of supplemental oxygenation movement of the patient onto the left side or onto all four and IV fluids. Um, okay. If late deceleration persists on fetal heart rate tracing, then urgent C-section is indicated, as continued heteroplacental insufficiency can result and result hypoxemia will result in death of the fetus. This patient has persistent and recurrent late decelerations on her fetal heart rate monitor prior to onset of labor, making urgent C-section the most appropriate next step in management. Bed rest in the left lateral decubitus is part of the initial management of late decel and uteroplacental insufficiency. Moving a pregnant patient to the lateral position relieves the pressure on the outer and inferior vena cava caused by the gravid uterus, which may improve blood flow to the fetus. However, this patient has had persistent late decel over an hour, making urgent C-section warranted. Failure to proceed with the delivery may result in profound fetal acidemia and even death. And then induction of labor It's not appropriate for this question. Inducing labor and the consequent uterine contraction will likely worsen the uteroplacental insufficiency and subsequent fetal hypoxemia. This fetus is already in distress and will likely not tolerate labor. Okay, next.
Yes. A previously healthy 63-year-old woman comes to the physician because of 2-day history of severe right orbital headache. She takes no medication. She does not smoke cigarettes or drink alcohol. Her blood pressure is 175/90. Supple neck. Visual acuity 25/40 in the left eye, 25/60 in the right eye. Cup disc ratio 7/10 on the left eye and 9/10 in the right eye. Neurological information shows no abnormality. Which of the ESR is 15? Which of the following is the most likely diagnosis?
Right. Yes, that is 15. Let me see what this is. No, no.
Ready?
One moment. Yes. Acute glaucoma refers to an increase in intraocular pressure and consequent optic nerve damage. Angle closure is the most common cause of acute glaucoma, whereas open-angle glaucoma is typically a chronic and progressive optic neuropathy. The closure of the anterior chamber angle leads to a sudden accumulation of aqueous humor in the eyeball as well as increased intraocular pressure. Some patients' eyes are anatomically predisposed to acute angle closure glaucoma, as is likely the case of these patients. Secondary cause of acute glaucoma include sulfur-based medication like the pyramid and the accumulation of blood or uh, acute angle glaucoma includes sulfur-based medication like the pyramid and the accumulation of blood or inflammation in the angle. Patients typically present with acute unilateral vision loss, eye pain, light hair loss, headaches, nausea, vomiting. Ocular examination commonly shows a red eye, corneal cloudiness, and polyreactive mid-dilated pupil. Eye cup this ratio greater than 7 is consistent with glaucoma. Gonioscopy, which assists in visualizing the angle closure, confirms the diagnosis. Management involves acute control with beta blockers, alpha agonist, meiosis causing medications, and acetazolamide or mannitol to decrease intraocular pressure. Definitive treatment is laser, peripheral iridotomy, and cataract surgery. Okay.
Next. A 27-year-old woman comes to the physician because of progressive rash and easy bruising during the first 2 weeks. She has no history of serious illness, takes no medication. She enjoys horseback riding. She enjoys horseback riding. Uh, oh, and first noticed the rash on her legs when she took off her riding boots. She initially believed it was caused by the long time spent horseback riding that day. Her pulse is 62 per minute, respiration 12 per minute, blood pressure is 113/77. Examination shows blood-filled blister on the buccal mucosa. Is petechial rash. There is petechial rash over the shins and the dorsum of the foot. Lab studies show platelet function 9,000. Prothrombin time is 12 Partial thromboplastin is 29. Results of the thyroid, liver, renal function test are within the reference range. A blood smear shows decreased platelet. Which of the following is the most appropriate next step in the management?
BT is BPG. What's the normal blood
Normal platelet count is 1.5 lakhs to 3 lakh.
this one therapy? Uh, Splenectomy, the liver, blah blah blah. They're all fine. Let me some. Okay. Ready?
Yes.
It is prednisone therapy. Immune thrombocytopenic purpura is caused by antibodies against platelet surface antigen, most commonly like the GP2B3. It can be primary or secondary to a variety of conditions such as HIV, Hep C, lupus, CLL, following a viral illness. May be idiopathic. It typically presents with thrombocytopenia with platelet counts less than 100,000. Patients often present with petechiae purpura, mucosal bleeding like epistaxis, vaginal bleeding, GI bleeding, which may occasionally result in profound hemorrhage if severe. Lab studies are otherwise fine, but bone marrow biopsy often shows megakaryocyte hyperplasia. Okay. It can be treated with steroids such as prednisone or IV immunoglobulins but may require splenectomy in refractory cases. As the antibodies responsible for ITP are typical IgG, which can cause the placenta, it- in cases of pregnancy, the fetus may be at risk of antibody-mediated destruction of platelets. It's not the platelet transfusion. It's a potential treatment for ITP, for patients with ITP and life-threatening hemorrhage. Other times, platelets can be given to patients with ITP is if there are acute neurologic changes associated with the condition, or if an urgent or invasive procedure is needed. Given this patient mostly benign presentation, this is not mandatory. Yet it should be considered given her severe thrombocytopenia. Splenectomy is definite treatment for ITP. Patients who have been refractory to steroids and immunoglobulins or other therapy can be considered for ITP. For splenectomy, sorry. Right. Next.
So like if there is no life-threatening hemorrhage, so we will not gonna give platelet. And
Mhm.
even if platelet is very very low like this,
Yeah, that's what they're saying. Mhm.
is it true?
Mm.
Okay.
No, this is a recent nbme, so I'm guessing it's true.
A 69-year-old woman comes to the clinic for a routine examination. He says he feels well. He has hypertension, hypercholesterolemia, osteoarthritis, lisinopril, hydrochloride, lovastatin. He smoked 2 packs of cigarette 30 years, but quit 8 years ago by sensor within normal limit. Which of the following is the most appropriate screening test to decrease the patient's cardiovascular event? Ready?
Mm, yeah, it is abdominal ultrasound. Abdominal aortic and triple A most commonly occur in male smoker with a positive family history and history of atherosclerotic disease. Other risk factors include hypercholesterolemia, hypertension, and trauma. They commonly occur in the infrarenal abdominal aorta and may present as part of a pulsatile abdominal mass, if large and in a thin patient. Ruptured aneurysm require emergency surgical intervention and repair. Chronic aneurysm are typically asymptomatic. USPST recommends using ultrasound to screen for abdominal aortica in men 65 to 75 who have a history of tobacco use. It's not echo, can be used to evaluate cardiac function in a patient with suspected heart failure. Patient may present with dyspnea, autopnea, lower extremity edema. USPST does not currently recommend echo as a screening tool for asymptomatic patients. Okay, next.
If a previously healthy 37 years old woman comes to the office because of 37-year-old woman comes to the office because of 4-week history of intermittent difficulty swallowing liquids and solid, the patient describes sensation of something lost in the center of the chest and says that the sensation is often painful. He has not had any other symptoms. He takes no medication. Examination shows however which of the following is the most likely diagnosis. Mm, you are in between B and D. B and
It's
E.
no B and C. I guess I'll
TRD does not cause difficult and solid liquids. Okay, it is essentially spasm.
yeah. Um, Esophageal spasm. This patient likely has diffuse esophageal spasm. Diffuse esophageal spasm represents with severe dysphagia and chest pain, often acutely in the setting of swallowing. Patients typically present with abrupt onset of chest pain lasting for a few minutes to hours that is often self-terminating and frequently in response to consumption of triggering food or in the presence of an impacted food bolus. It may also occur in the absence of swallowing, such as in association with GERD. Barium swallow will show like a corkscrew esophagus. Esophageal manometry can also be used in the diagnosis of esophageal spasm, which measures the pressure generated along the length of the esophagus and lower esophageal sphincter. Spasms are typically not associated with weight loss or vomiting or undigested food. It is not GERD. Typically presents with cough, sour, or metallic taste, chest discomfort, and nausea. It's often worse when supine or following the ingestion of trigger food would not be expected to cause issues with swallowing. And it's not, what was that? Hiatal hernia, often asymptomatic and present with epigastric or inferior chest pain, acid reflux or nausea. Dysphagia is generally less likely to be present unless the patient experiences a severe paraesophageal hernia. Okay, next.
And 8-year-old girl is brought to the physician because of 2-week history of vaginal discharge and itching. He has no history of serious illness, receives no medication. Vital signs are within normal limit. Physical pelvic examination shows erythema of the perineum and thin white vaginal. This is the remainder of the examination shows no abnormal when bound. Preparation of the discharge show elliptical cell, epithelial cells and a number of the leukocyte. Addition of KOH preparation to the discharge produces motor. Which of the following is the most likely explanation?
already?
Yes. Why foreign body? He's not a kid. He's not a baby.
And she's a foreign body is not in a baby. I thought it was in a kid.
No, no,
It,
8-year-old girl is very mature, isn't it?
oh, not really. Okay, I guess. The most the most likely explanation for the findings in this prepubertal patient with non-pathologic vaginal pruritus and redness in the perineum and non-pathologic vaginal discharge is non-specific vulvovaginitis. Vaginal odor may also be present. These factors include progenital hygiene, exposure to irritant substances like tight clothing, and obesity. While non-specific vulvaginitis is a common cause of vulvaginitis in this age group, other causes like infection and foreign body should be ruled out with appropriate evaluation. This typically includes physical exam, vaginal culture, wet mount in KOH testing of the vaginal discharge, and NAT for STIs for patients who may be at risk. These tests will all be expected to be normal and non-specific vulvaginitis, as they were in this case. It is not foreign body aspiration. Foreign body in the vagina often presents with genital discomfort, purulent or malodorous vaginal discharge, or vaginal bleeding in a prepubertal child. It most commonly occurs as a result of a child's curiosity and exploratory genital play. Diagnosis is often made via physical exam with the child in the knee chest position. This patient thin white discharge, no vaginal pain, and of bleeding and no identification of foreign body on physical exam rules out the diagnosis. Okay, candidiasis involves overgrowth of candida. Candida is a cause of vagina can be distinguished from other potential caused by abnormal, often thick white vaginal discharge with negative KOH testing and pseudohyphae on wet mount preparation. Risk factors for candida vaginitis include the use of medications, antibiotics, and OCPs, use of intravaginal or intraenteric or IUDs, and in an immunocompromised state. Okay, next.
4 days after undergoing open developmental intradocumentary fracture of the right hip, sustained fall, 70-year-old man, sudden onset fever and rigorous central venous catheter has been placed preoperatively in the right internal jugular vein for vascular access. She received perioperative cephalozolin for 24 hours. Her temperature is 39.2, pulse 104 per minute. Respiration 60 per minute, blood pressure is 80 by 50. Examination shows well healing incision. There are no localizing signs of infection. Which of the following is the most likely to have to be prevented? Ready?
Yes. It is appropriate barrier precautions during catheter insertion. This patient presents with fever, tachycardia, hypotension in the postoperative period, which should raise suspicion of sepsis. Given the lack of localized signs and the well healing incision, the most likely source of the infection is her central venous catheter. Central line associated bloodstream infection is a common occurrence and can cause significant mortality. Unfortunately, practices regarding barrier protections during placement of central lines may vary. The CDC recommends hand washing and antisepsis prior to beginning the procedure, followed by use of maximum barrier precaution with sterile gloves, gown, cap, mask, and large sterile drape during catheter placement. Central line should be kept covered and clean, and hands should be washed and sterilized prior to using the lines. Central lines should be removed once they are no longer needed. Blood culture should be obtained and the line should be removed as soon as the bloodstream infection is suspected. Central line associated bloodstream is treated with IV antibiotics, IV fluids, and pressure as needed. It's not continuous cephaloxin prophylaxis after cefazolin after 24 hours would not only have prevented this patient's central line as infection. Routine antibiotic prophylaxis is not recommended following placement of central lines. The use of sterile techniques and maximum barrier precaution during central line placement is much more appropriate for preventing, yeah, central line. Next.
17-year-old girl is brought to the physician by her mother. She is concerned that her daughter has never had a menstrual period. The mother reports that her own menarche occurred at age 13 years. Her own menarche occurred as a 13 years. The patient has no history of serious illness, no medication. She has never been sexually active. She is 5 feet 8 inch tall, weight 66 kg, BMI 22, blood pressure 100 by 60, breast development in the sexual maturity training stage 5, hair development in similar to the external jelly relation. Insertion of the speculum in the vagina is difficult. Insertion of the speculum in the vagina is difficult. The cervix cannot be visualized. Uterus is not vulnerable. Okay, ready? Tell me the MRI confirms the absence of the uterus. Which of the following?
One moment, please.
Wait, can you remember that box?
Mm-mm.
Uterus present or absent? If uterus is absent, then what next? We have two diagnoses: androgen insensitivity. So you need to do karyotype analysis, isn't it?
Give me a second.
The algorithm one.
Oh no, I cannot remember. I'm not good with those tables.
Okay,
Those
I
it's
have
kind
a
of
very bad habit of remembering those things.
with those table. Stereotype analysis and AIS androgen insensitivity syndrome is caused by defect in the androgen receptor complex, resulting in genetically 46XY male developing a female phenotype. Testes are present and produce testosterone normally, but absence of functioning in androgen receptor prevents hormone binding and thereby prevents development of male sexual characteristics. Patient present with female external genitalia, scan, pubic, and axillary hair, absent uterus, fallopian tubes, and rudimental vagina. Results of lab study will show increased concentration of testosterone, estrogen, and testosterone, estrogen, and luteinizing hormone. Menses will not occur because of the lack of cyclic progesterone and estrogen and the lack of functional uterus. The testes of these patients cannot functionally produce sperm, and patients are at risk of developing testicular malignancy. In order to confirm the diagnosis in this patient, the next best step is karyotype analysis to definitely confirm it's a 46XY karyotype. Gonadectomy is an essential part of treatment of patients with AIS. This is because of the increased risk of testicular cancer in this patient population. However, given that this patient has not yet undergone karyotype confirmation of the diagnosis, this answer is incorrect. Okay, got it. Next.
There is one question where gonadectomy is the answer.
Yeah, I think we saw the question like it was yesterday or the day before. So that's why I was confused. So, but that question, I remember they had already told you that they did the karyotype and the person was the whatever, the patient was XY. So now they were asking what's the most appropriate management. So that's the key. If they already tell you the karyotype, they already tell you they did the karyotype and is a guy XY, then the next step is gonadectomy. Now, if they don't tell you they did the karyotype, then you have to confirm that it's a guy, so you do the karyotype.
Okay. Can you tell me the diagnosis just looking at the picture?
Um, the boot shape,
Yes.
it
Now,
looks like
what is your
uh,
diagnosis?
the boot shape, the TOF.
Yes. Now, the pathophysiology.
Like, you want me to answer the question based
Yes.
on that? Okay. This patient might have which of the following sets of cardiac abnormalities?
In this question, you don't need the explanation. Yeah, you don't need anything. Okay. Ready?
Yes, already. PSD and right ventricular aortic obstruction. This infant with difficulty feeding, hypoxia, boot shaped heart, chest cellular presentation with tetralogy of Fallot. POF consists of pulmonary infundibular stenosis overriding aorta, ventricular septal defect, and right ventricular hypertrophy, resulting in right to left shunt, with cyanosis first noted in infancy. Right ventricular aortic obstruction eventually leads to right ventricular hypertrophy. The murmur heard with TOF which is typically a systolic murmur best heard at the left lower sternal border. It's caused by right ventricular obstruction, not as often by the VSD. Paroxysmal cyanosis that occurs during periods of crying is a classic presentation, and these episodes are referred to as death spell. Patients amid one of these spells often exhibit rapid deep breathing agitation and progressive cyanosis. These periods of cyanosis occur because of the transient obstruction and occlusion of the right ventricular of blood tract, leading to decreased blood flow to the pulmonary circulation. Although the cause of the underlying transient obstruction is unclear, treatment of TOF is operative repair, which aims to relieve the right ventricular obstruction, close the VSD, and separate the pulmonary and systemic circulation. Procedure is usually performed in the first 6 months of life and almost always within the first year. Nice.
A 14-year-old girl is brought to the physician where her parents find 8 month history of shaking her hands. 8 months history of shaking her hands that occurs when she tries to do things that require steadiness, such as writing, threading on a needle, doing artwork. Her teachers have reported that her handwriting is sometimes difficult to read. The shaking is worse when the patient is stressed or tired, but when she says she is not bothered by it, she has no history of serious illness, takes no medication. Her father also has mild shaking of the hands. Patient is 57 centimeter, weight is 43 kg, BMI 17 kg per meter square. Vital signs are normal eyes, ocular movement, mild gaze, nystagmus. There is a first tremor of the hands when she holds her arm outstretched. When the patient draws spirals or straight lines, the tremor causes waviness and drop. There is no dysmetria, finger, nose, or Hilton test. Which of the follow the remainder of the examination should which of the following? What is your diagnosis?
I don't know. It looked like essential. I don't remember if essential tremor was when you are. It doesn't look like essential tremor. It looks like another tremor.
No, it's a essential tremor. You are on the right track.
Oh, okay.
Ready?
Okay. Weird. Okay, so it's not further treatment. What threw me off was the nystagmus. I was like, maybe it's something pathologic since you have nystagmus too.
Yes, the
Yeah, because I know essential tremor is familiar one, but why she has nystagmus? Anyway, essential tremor is a common adult action tremor that most often presents in bilateral as a bilateral tremor of the upper extremity. Action tremors are exacerbated by activity and sustained anti-gravity postures and improve with rest. Okay, so this one improves with rest. Parkinson worsens with rest. Essential tremors specifically are exacerbated by stress and improve with small quantities of alcohol. The tremors may involve more body regions over time, including the extremities, head, voice, eyes. Oh, that's why. The pathogenesis of essential tremor is unknown, though it's commonly irritable. Diagnosis is clinical and typically no further diagnoses are indicated. The first line treatment is as needed or schedule propranolol, beta blocker medication. Okay, next.
an 11-year-old girl is brought to the office by her mother. Brought to the office by her mother because of 1 year history of behavioral issues at school. The mother reports that her daughter become more isolated and her grades have fallen from A, B to C. The patient is also concerned about the daughter's appearance. She has dyed her hair again. As an asymptomatic haircut, there is no history of serious illness. So when her mother leaves the room, the patient says she is tired of everyone at school. She feels that she is in the wrong body. She also hates her name in Refer in the gender neutral one. She says that she has felt this way the entire life. She has tried to talk to her parents about the feelings, but they dismiss her things. Mm, The patient is great risk of which of the following disorder? Ready? Okay.
Mm, Ready. It is MDD. Mm. This patient is experiencing gender dysphoria. Transgender person is an individual whose sex assigned at birth differs from their gender identity. While gender dysphoria is a diagnosis that refers to clinically significant distress caused by difference between individual sex assigned at birth and gender identity. Wait, transgender is individual whose sex assigned at birth differs from their gender identity. So they're female and they want to be male. Where gender dysphoria is a diagnosis that refers to clinically significant distress caused by difference between an individual's sex assigned at birth and gender identity. What's the difference? It's the same thing. Many, but not all, transgender individuals experience gender dysphoria. Oh, guess it's not the same thing. Which commonly motivates them to seek gender affirming interventions, like changing the names or pronouns, pursuing hormonal or surgical treatment so that their external appearance aligns with the gender identity. An individual assigned sex in the gender discern an individual's assigned sex is the gender discerned at birth, while gender identity refers to patient's internal sense of their gender. Though many individuals possess a sense of their gender identity as young children, Individuals who experience gender dysphoria commonly begin to experience their gender identity in adolescence during the identity versus role confusion stage of psychosocial development. This patient expresses having a gender identity different from her assigned sex. This is confirmed by her distress over her parents' name and social roles. MDD is the most common psych comorbidity for patients with gender dysphoria, followed by specific phobia and adjustment disorder. Gender affirming treatment has been shown to decrease MDD and suicide rates. Body dysmorphic disorder manifests as preoccupation with a perceived flaw in physical appearance, leading to repetitive behavior like checking a mental act. This patient expresses distress about her body as a whole, not a particular flaw. She also possesses a sense of being internally different from other individuals of her assigned sex, which is more consistent with gender dysphoria, making risk um, for MDD more likely. Okay, next.
The MDD one becomes difficult for me.
What do you mean?
Okay. A 13
What?
year old, sorry,
Oh, what do you? I didn't understand. What did you mean?
like I am missing the MDD again.
No, this was not MDD. She doesn't have MDD. Like she doesn't. They are just saying that she has gender
She
dysphoria.
has gender dysphoria, yes,
Yeah,
I got that. Okay.
yeah. So they are saying what is she at risk for? So she doesn't have. There is no signs of MDD here. She doesn't have any symptoms of MDD. They are just saying that in the future, what is she most
Why it
likely?
cannot be body dysmorphic disorder?
That's why I was between those two. That's why I read that the body dysmorphic one, but isn't the body dysmorphic? I guess it's just the fact that you need to know that people with gender dysphoria in the future they can develop MDD. It's just a fact. Um, yeah, it's just the fact that you need to
And
know.
how we can differentiate between body dysmorphic and gender
Mhm.
dysphoria?
Oh, usually it's pretty clear in the question. Like this one is like in gender dysphoria, the is a boy. He was born a boy, and he feels like he's a girl. So he feels like he's trapped in a he's a girl that he's trapped in a boy's body. In
Okay.
body dysmorphic is usually like the the girl is a girl. She knows it's a girl. She doesn't have any issues with her gender. She just feel like her nose is big.
Oh, okay.
So and she keeps checking and she's mad because she thinks her nose is big. So she keeps checking in the mirror, and then and then when you look at her nose, the nose is actually not big. But it's nothing with the gender with her gender. No issues with her gender.
A 13-year-old boy is brought to the office by his father because by his father is concerned that his son seems to have small penis. The patient has no serious illness, takes no medication, vaccinations are up to date. Vital signs are within normal physical examination, small about long, downy pubic hair at the penis. The scrotum is pink and penis is 3 centimeter length. Which of the following is the most appropriate next step? It is normal. Okay.
I don't
Ready?
even know what's the normal length of of the penis. Okay, it's reassurance that the patient's sexual development is normal. Puberty is a normal part of adolescent development. In males, puberty begins around 9 to 13 years old with an average around 10. Puberty progresses to a predictable pattern with variation in the onset and speed of advancement through the developing stage. Sexual maturity ratings of teenage stage include the sequential changes in pubic hair, external genitalia and breasts. These changes range from 1 to 5. This patient has likely teenage stage 2 for pubic hair and external genitalia development, characterized by sparse pubic hair along the base of the penis and enlargement of the testes and scrotum, with scrotal skin texture changes. As the patient progresses to stage 3 and 4, enlargement and increased size of the penis is to be expected because of this patient age and current tennis stage on physical exam. Reassurance is more appropriate next step.
Next. A 57 years old woman comes to the emergency department 1 hour after the onset of left side adjustment shortness of breath. The patient is exacerbated by inspiration. She has no history of she has no history of exertional chest pain, shortness of breath. She has received estrogen and progesterone replacement therapy since menopause 7 years ago. Her temperature is 38 degrees Celsius, pulse 100 per minute, regular respiration 20 per minute, blood pressure is 120 by 80, a rub and a decreased breath sounds are heard over the left posterior hemithorax. Heart sounds are normal. Examination shows lower extremity show no abnormality. IBG pH 7.48, P CO2 28, PO2 65. An X-ray of the chest show blunting of the left costocranic angle and the waist shape opacity. Uh, in the left lower lobe, ECG show right heart strain. Venous Doppler ultrasound of the lower extremity show no abnormality ventilation for long skull. Shows a perfusion defect in the left lower lobe are consistent with high probability of the pulmonary embolization. Following is the most appropriate next step. Ready?
Right. One moment. Perfusion defect in the left lower lobe and are consistent with high probability of pulmonary embolism. Hmm. Let's see. pH is basic. PCO2, so respiratory alkalosis. Respiratory alkalosis. Choo, 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 choo. Okay, let's see. No additional, let me see, no additional studies are indicated. This patient presents with signs and symptoms of pleuritic chest pain, cough, hypoxia, and tachycardia. This constellation is suggestive of PAP. Is a common disorder caused by occlusion of pulmonary artery with resulting impaired blood flow to a segment of the lung. Risk factors include immobility, presence of DVT, obesity, um, okay, recent surgery, pregnancy, and use of OCP, hormone replacement, smoking, trauma, fracture to lung bones, and inherited hemophilia. P presents with chest pain, shortness of breath, hypoxia, though seldom are all common features of breast. Yeah. P are often undetectable on chest X-ray, but emboli with infarction can be seen on chest X-ray by secondary signs such as wedge-shaped areas of infarction or via the Western mark sign of unilateral oligoemia. The test of choice for diagnosis is CT angiography of the pulmonary artery in cases of high test probability. However, if the patient is unable to undergo this scan for any reason, ventilation, perfusion, lung scan can suffice for diagnosis as seen in this case.
Why you
Okay.
can? Why she cannot
That's the
go?
part I don't understand. Did they say
Huh?
anything
Yes. Is
about
ERPR therapy and menopause is the contraindication of CT pulmonary angiography? I don't think so.
no? It's not where was I? Where is city and geography? D. Did I pass D? Where
Yeah.
is the D? Oh, right here. Spiral city of the chest and pulmonary geography are the test of choice when it comes to PE. However, this patient has undergone a ventilation perfusion lung scan showing a defect with high probability. So further imaging is unnecessary
So
to confirm
a
that
venous duplex ultrasonography of the lower extremity is a ventilation perfusion. Oh, sorry.
this patient can
Already
start.
she has gone a ventilation perfusion scan where there is perfusion defects. So they have already done the most appropriate test. So why you should do another appropriate test? You got my point.
I thought the most appropriate was pulmonary angiography.
No, CTPA or VQ scan. If CTPA cannot be done, then VQ, isn't it? I think so. Okay, this is a bit confusing question. Okay, let's drop it. Next, an 80-year-old woman who resides in a nursing care facility is brought to the office by a nurse because of a month history of lower abdominal pain, constant lower volume urinary incontinence that now requires an use of absorbent pad. She also had frequent urinary tract infection. She has hypertension, type 2 diabetes mellitus, dementia. Her medications are insulin and labetalol and donepezil. He appears frail, sits in a wheelchair. She is 160 centimeter, weight is 51 kg, BMI 20 kg, barometer survival time within normal limit. Abdominal examination shows a soft, non-tender midline mass below the umbilical, which is the most likely cause.
What was donepezil?
Constant low volume. Yes. Ready?
What what was donepezil again? It's like
Sorry. Donepezil, rivastigmine, galantamine, Alzheimer. Anticholinergic.
anticholinergic. Mm. Give me a second. The cruiser overactivity. Okay. So is I knew it was neurogenic bladder. Overflow incontinence is caused by underactivity, underactive or flaccid detrusor. You do detrusor overactivity. Okay. Urgency. Okay. Um, underactivity of flaccid detrusor muscles. Okay. Or bladder outlet obstruction and is characterized by chronic urinary retention and chronically distended bladder. Patients will have increased postbiotic residual bladder volume. It may be caused by physical barriers such as tumors or urethral stricture, neurogenic lesions, or an adverse effect of some medication like anticholinergic. This patient overflow incontinence is likely due to neurogenic bladder, potentially related to diabetes or primary neurologic disease. When the intravesical hydrostatic pressure eventually overmoves the internal and external sphincter, causing pressures, the patient will experience passive leakage of urine. This patient likely has overflow incontinence with passive leakage of urine, frequent urinary tract infection, and a soft non-tender midline mass in the lower abdomen that is likely chronically distended bladder. Overflow incontinence is treated with managing inciting conditions, time-voided and placement of a catheter. Medication adverse effect can directly correlate with overflow incontinence in some cases. However, this patient is not taking any medication that are known to cause and incontinence, such as anticholinergic. So donepezil is not anticholinergic. This patient overflow incontinence is more likely due to neurogenic bladder.
Oh, I said wrong.
But donepezil is not anticholinergic.
Yes, yes.
Mhm.
Final question. An 18-year-old man is brought to the physician. An 18-year-old man brought to the physician by his parents because of 1 week history of increasingly severe pain and locking mechanism in the right knee And last week his knee was twisted and bent, and he was pinned during a wrestling match. He was unable to finish the match. He has a serious illness, takes more medication while within normal limit. Examination from McMurray test of the right knee produced pain on the medial joint line. Lachman test, abduction, and stress test are negative bilaterally. Its arterial dorsal spadies are 2 plus bilaterally. Sensation to light touch over the lower extremity. Extra of the right knee shown on MRI. The right knee is shown. Which of the following is the most appropriate next?
Ready?
Yes.
Is arthroscopy an operative repair of the knee? The meniscus is a crescent-shaped fibrocartilage path between the tibia and femoral condyle that helps to dissipate flooding forces on the knee. Acute meniscal injury commonly occurs during a twisting motion, with chronic meniscus injuries usually occurring in older patients because of repetitive degenerative tears. MRI is the imaging method of choice to evaluate for meniscus. Meniscus injury typically are managed conservatively with rest and physical therapy if there is minimal swelling, poor range of motion, um, and lack of severe pain or mechanical symptoms such as knee locking. In the setting of meniscal tears presenting mechanical symptoms, referral to orthopedics for operative management is indicated. Operative interventions include open intervention or arthroscopy repair and debridement. This patient is presenting with swelling and locking sensation with an MRI showing meniscus injury and joint effusion. Because of the mechanical symptoms and continuous severe pain, operative management is indicated. Oh, it's not here.
Okay, we are done.
Okay. See you tomorrow for block 4.
Yes.
Okay.